Yeah, that's the way my status was initially. He may need to or click in the lower left of the screen, join with audio. Orlando, that is.
Did you hear that, Orlando?
Yep, that okay, you had it. You had it for a second. Watch your screen where the when the red icon goes on with a line through the microphone, yeah, that's it. Now leave it that way. Perfect.
Hey, Chin, is your audio working?
Yes, sir.
Okay, good. All right. Who are our guest speakers tonight?
Our guest speakers will be Dr. Karen Lerman, Dr. Rael Khan from USC, and Wilhelmina Castro from a group who deals with these types of situations, post-traumatic stress, and different things like that. I can tell you that Dr. Lerman is signing in right now. She was a little,
I'm
she
right
was giving
here.
me, asking me,
Hey,
is
Chin.
that
I'm
you?
here. Yep.
You made it.
Good to see you again.
Good to see you again, and hope all is well. So we got one of our guest speakers here, so I'm sure the other two will be not far in tow.
And you said
So
Mary Cron?
Dr. Rael Khan.
Rael Cron.
Rail Khan, he's Department of Psychiatry. Well, I'll introduce everybody.
Yeah,
Chin, whenever you turn it over to me, once everybody's here, I can give like the overview and introduce our speakers.
you
Okay.
got this. We got
And
this.
We got it.
Dr. Lerman, I made you co-host in case you need to present. Do other guest speakers need to present as well?
And we are going slideless because we wanted
Oh,
to be more of a conversation
all right.
and keep it interesting and not just talk at you. So
Mhm.
we're very excited to be here.
Oh,
All
this is
right.
great.
Looking forward to it.
And I will tell you, just looking at the attendance list right now, we've got a number of members from our LAFD CERT call out team who I told you about. Mostly everybody I think who is here tonight did work the Palisades fire and understand definitely what was going on. And we've got a number of our other CERT people, and we've got people from around the country, CERT and it's emergency managers and different things like that. So it's kind of cool. You got a cool audience out here tonight.
Some
All right. And I see Wilhelmina has checked in. She is here with us. So very nice. So
just
and to everybody out there, I haven't said good evening to everybody. It's good to see everybody here. 6:56 here on the West Coast, and across the time zones. Stacy Burns, always one of my favorite people coming out of Florida down there. She's 3 hours ahead of us, and is always here. And everybody in between. And Doctor, we do sometimes, and I don't know if they're here tonight. We do have people from as far as Brazil who attend these different sessions that we do. And of course, I don't think you've met my colleague over there. That is Patrick Botts Forbes, and I'm pointing, which is not always which is not polite, but I like to point at him. Something like
Pointing at
this.
random spots on the screen that I am not at.
Yeah, absolutely. And he and I are well, I run the South Bureau, he runs the Central Bureau, yada yada. So looking good here. So 31, and we're looking good here. So Patrick, it's near the 3 minutes, near the top of the hour. We're
Yeah.
looking pretty good up in here.
So we typically give everybody a few more minutes after the top of the hour to get in. Usually start about 3 minutes after, just because people tend to sign on to Zoom right at the start, and then it takes them a few minutes to get in, update their client, deal with technical issues. So we tend to see a spike right at 7 o'clock, and then it tapers off about 7:03, and that gives everybody a chance to get in, and then we'll introduce you, and then you can go ahead and get started. We are
And
sharing this.
Doctor, I have a question for you. Usually when I do these sessions, I'm usually 5 minutes after the hour. Patrick's always 3 minutes after the hour. Does that say something about our psychological makeup or something like that? Maybe like seeing spots on the paper, something like that?
I don't know. I'll give you my analysis at the end of the meeting. I need more data.
See, I look
Um,
at the numbers. When the numbers stop climbing, that's when I begin.
Okay, so
Yeah,
Rael is not here yet, but we can get started without him. He'll
absolutely.
join. I just tried to call him.
And Patrick, of course, with all the bad jokes aside, don't forget. I'd like after you do your opening, I'd like to give a couple of opening comments to the group as well.
No.
Oh, okay.
Looking for my
Psychological
friend,
warfare from here on. It's you
Looking
and
for
me
my
and the back
friend Freddie
scratch.
Muse. I don't see Freddie yet.
Freddie should be coming in shortly as well. So I know he signed up. So we'll get it going. But a
We have
nice.
Prince George's County, Maryland.
Yeah, I've seen them here before as well, and we've got Portland, we've got Stacy from Florida. I always love the fact that we have very wide and diverse audiences that attend these sessions. So thank you guys for coming from the multiple time zones.
This is Sally. I just want to thank Patrick for a fantastic Encino Park disaster preparedness review and all that. It was really, really well done all over, I think. I mean, we could see a lot of places for improvement, which is why we do these, exercises. And it was just a great turnout.
Well,
Thank you so much.
was Christy and the Valley team up there. So
That too, yeah.
Mhm.
But you were there helping out and just pointing out things that we could do better,
Hmm. Well,
which
I
is
wish we were
what
able to
it is.
make we did a search and rescue in an apartment building last weekend, and we did it. Christy was there as well as several other coordinators, Pat Hall, who's on with us tonight, Chen, of course. And we got to do in-building search, and we had 7 different apartments spread across 4 floors, and it was just the teams getting to go do it over and over and over again. And I think universally we saw great improvement from um, each run through as they got to do it over and over again.
Yes, that was a fun Sunday. I was there. I really thoroughly enjoyed it.
I agree.
It was fun.
We had a lot of fun with that particular exercise because it's one of those rare times where we get to use an actual environment like like an apartment building like that with units that allow us to come in and out and go into the different rooms. A lot of times the artificiality of using some other type of space, kind of takes away from it. But this was really great because we had a real building. Some of the units were furnished, some were not, some were black, some were pitch black dark, some had light in them. It was really a lot of different things we could do, and that probably made the environment made everything work.
I
I
just wish I
probably,
could have seen some of the run throughs, some of the scenarios you put the teams through.
yeah, I think I put some people through additional trauma because I stepped in to be one of the victims, and so I was laying down on a mattress with wires on me, and they were glowing as if there was a power surge across my body. So they obviously didn't touch me. But then I had to instruct them on what to do with the other victim. So after they were done moving on from me, I basically started speaking and scared the living crap out of them because they thought that I was a mannequin. So there you go.
I don't know what that says about you though, Pat, that they thought you were a mannequin.
I missed that one. Darn it.
So we have
I wanted to
attendees
see that.
from Washington, Michigan,
D-
Redlands, and Brazil. Welcome.
Brazil is here?
Brazil is here.
All right now.
Yes, just here.
And
And of course, we
love
are streaming
it.
on YouTube live right now, and this presentation will be up for review after.
All right.
Okay,
Tennessee.
we're all here, so anytime you're ready, we're ready.
All right, we'll go ahead and get started. It is 7:03 p.m. Today is the third Wednesday of the month of April, and thank you for all of you for coming and joining us. This is our third Wednesday of the month CERT continuing education training that is Community Emergency Response Team. And of course, we welcome anyone and everyone who wants to attend. You don't have to be CERT trained. You don't have to be from Los Angeles, even though we are from Los Angeles, and this is the origin of the Community Emergency Response Team program. But this is a worldwide program, so thank you for attendees from all around the world attending these. Every month we have different topics ranging from beginner, intermediate to advanced topics, and occasionally we have guest speakers such as this month. This month we bring in guest speakers to talk about a really important topic that I think it's really under-focused during the trainings, mental health. And it's something that I think universally that's really put behind the scenes or really downplayed. Um, we saw over the last 100 years or so with wars that more recently our soldiers are coming back with PTSD, with trauma that is not addressed soon enough, quick enough, or possibly ever. And one of the things that we can look historically at is when soldiers came back from World Wars One and Two, they came back on a boat with their fellow soldiers and they were able to commiserate. They were able to talk about the trauma, the shared trauma that they had But now, as they come back from wars and our first responders come back, they don't have that time to decompress. They're put back into reality, sometimes overnight, and it is at a detriment to them and to their families and to their fellow first responders. So it is a topic that I'm so glad we have these guest speakers to talk about. Chin.
And it is my pleasure to be a part of this. And I actually brought the subject to our attention and made it a part of our training. Based on what I had seen, as you know, this training was inspired by the work that we did. We, the CERT team, the LAFD CERT team, did during the recent Pacific Palisades fires. And, as always, we did our usual best out there. But one thing that kind of popped up on us in the after time was just how stressful and how traumatic this experience just for us was. And I'll tell you, for me, it was an interesting kind of situation. I everybody reacts to these traumas, and Dr. Lerman, you and I have talked about it. Everybody reacts to traumas differently. Everybody handles it differently. For me, I think, and I've come to learn that my therapy after doing anything and everything is to write about it. And many of you guys know that through my outrageously long newsletters and different things like that. For me, that's how I do it. But what I didn't realize is that some members of the team around me were suffering. And it wasn't until they truly spoke up that I realized just how bad they were suffering. And when I started having conversations with these members, I immediately understood it. Let's take this to a different level, to the proper level, which is to get them mental services. And in fact, some of them just outright said, "We need somebody to talk to." And we did that. LAFD, mental health services were fantastic, and we did that. But it really brought up a much bigger issue. Our call out team, as many of you know, we support the LA City Fire Department regularly on different types of incidents. But I thought outside the box on this and I said, hey, if it's affecting our folks like that, because we don't see these types of things often, how's it going to affect our civilian responders who are certs, who are not part of the call out, who are in their neighborhoods, who are going to respond during a major power outage, an earthquake, damaging fire? Guess what? They're not going to react any differently than some of our people did. They will need that help. And like Patrick said earlier, it's not always emphasized when we're out here doing this CERT thing. We're emphasizing team formation. We're emphasizing understanding the incident response system and everything. And we're also telling people, hey, let's get out and do this. It's fun. There's another side to this whole thing that, especially for me, I've learned just since we've worked the Pacific Palisades fire, and that's why I kind of brought this subject forward. So that's kind of the background on it and how it came up. I want to take this time now to turn it over to one of our key speakers and not take up the whole night, which you know I'm capable of doing. I'd like to turn it over to Dr. Karen Lerman. The floor is all yours.
Thank you, Chin. I had the good fortune of being introduced to Chin through Freddie Muse, a CERT member, and we met for breakfast and had just a really deep conversation about some of the challenges faced, and we talked about the potential benefits of sharing some of our knowledge and experience and talking about new approaches to addressing stress-related mental health problems. Before I introduce myself and the other speakers in more detail, I wanted just to thank you guys, just a huge thank you for your service. As somebody who lives in Los Angeles, I'm in Los Feliz, not directly affected by the fires, but you know, I have to say there are so many people at USC where we work, many from the Altadena area. I know you were focused in the Palisades, but you know, who have suffered incredible trauma. And the fact that you guys are out there from the beginning and all the way through the cleanup and the support that you provide to the community, to the LAFD, to the survivors of these fires, as well as other you know, natural disasters that you show up for is it's just the work that you do is tremendous, and I'm so impressed, and I loved your newsletter, Chin. I thought it was great, and so we're really
Can you
delighted.
s-
Yeah,
can you say it one more time?
I just love your newsletter. Did we get that recorded? All right.
Don't
So,
feed his ego.
but it's really an honor for us to be here with you and to do, you know, in our own small way, to be able to give back by sharing what we know. So I'm Karen Lerman. I am a clinical psychologist by training. I also am the director of the Cancer Center at the University of Southern California. And I'm joined by my colleague, Dr. Rael Khan, who is professor and psychiatrist in the Department of Psychiatry at USC, and Wilhelmina De Castro, who is also a graduate of USC in the social work program. And all of us have been working in this area and starting a new program. And we're really eager to share what we've learned with you. And importantly, we would love to get your feedback and your input in addition to answering your questions. So we're going to start, the program we'll start with Rael, and he will give us background on stress-related mental health challenges, particularly those faced in the epidemiology, the rates of mental health challenges in early responders and other populations. And he'll introduce us to some new medicines, some new approaches that are being used to address mental health challenges, and particularly those that are related to stress and trauma. We'll then hear from Wilhelmina De Castro, who will share with us her extensive clinical experience working with individuals and groups who are challenged by mental health issues related to stress, who she sees in her practice. And then we'll take a pause to answer questions about the information. Then I'll share with you a program that we're starting. It's not going to be available for a while because there's lots of approvals that we need to go through locally and federally for this. But we would love to hear your feedback about if this is the type of program that you think would be helpful and would be of interest. And the feedback that you provide is actually going to help shape what we do. So that is our plan for tonight. We decided to go without slides because we really wanted it to be more of a conversation. So at points, we'll pause. We might ask you questions to share your experience, generally speaking. And of course, we want to have the question and answer and then get your input at the end as well. And I would say, feel free if you want to stop and ask a question at any time. You don't have to wait till that speaker has completed what they have to say. We're here informally just to be part of your community and to share and to get your feedback. All right. So with that, I will turn it over to Dr. Rael Khan, who will start off our conversation.
Great, thank you, Karen. I second that emotion with regards to just acknowledging all of you in the CERT community for the work you do. It's especially impressive to me, and I have extra thank you for it. The fact that, you know, you don't even get paid to do it, that you just do it out of the, whatever the calling you feel in your heart to do that. So it's inspiring, and I'm glad to be here amongst you for a little bit tonight. I'm a psychiatrist and also a researcher. My PhD in neuroscience has been, both historically and to the present day, really focused on understanding how the brain changes in association with different forms of healing practices for, both everyday stress, anxiety that we all have, and, the more clinically significant kinds like we see with post-traumatic stress disorder and depression. And so, I do clinical work at USC in the outpatient population, and also do some research. Some of the more interesting research that I've ever done is about to start with Dr. Lerman. And maybe we'll talk about that at some point. But, to just want to start out as Karen was saying, to talk a little bit about the two most common forms of suffering that we tend to see in relationship to exposures to major stressors. And those are, the formal diagnoses of major depressive disorder and post-traumatic stress disorder. And of course, there's a whole range of depression that is not quite, the fully diagnosable major depressive disorder that's quite common, that maybe doesn't impact people's ability to just live their lives in a kind of functional way, but still is, part of the human condition. But when it reaches a certain level of impact, which is really what we in psychiatry, the kind of tradition of psychiatry is to kind of set a diagnostic bar that is partly related to what kind of issues people are experiencing and the different, categories, but also partly related to, is it really impacting your capacity to have meaningful engagement with the two primary areas of life, love and work. So your relationships, your social world, and your capacity to meaningfully engage in, the work that allows you to put food on the table, etc. And so at some point, these different things, depression and PTSD, do get to a point where it's really a challenge to either, thrive in one or both of those domains. And that's one of the key things that we use to actually diagnose, something as a psychiatric disorder instead of just part of the, stresses of being human. And so when it comes to that, I wanted to mention a little bit about the prevalence of PTSD and depression, and the prevalence in the general population compared to the first responder population. And, the studies are never perfect for these things, how to get an accurate count of everyone in the country or all the first responders in the country. So you see a range, but, if you look at across the different studies that have been done, you get some averages that we kind of use to kind of be a best guess. And depression is probably, it's one of the two most common, highly prevalent psychiatric disorders in the world generally, and in our country as well. Something like around 10%, maybe a little bit less, maybe a little bit more, are experience a depressive illness in any given year. And meaning an episode where for, weeks, months at a time, the depression is really impacting their capacity to, thrive in any significant way. And if you look at, lifetime, the prevalence is close to 30%. So it's pretty big numbers, It is more prevalent among both women compared to men, and young adults compared to older adults. That has not always been the case, but that's a new trend that's been going on over the last 20 years or so. That's really noticeable. And in regards to first responders with depression, estimates are in the kind of 1 in 3 range. And that 1 in 3 range is some combination of PTSD and depression. There have been few studies that looked only at one or only at the other, but those that have put the rate of depression a bit higher than PTSD. which is true in the general population as well. It's worth noting, looking at this literature a little bit, that some studies find rates, in first responders more in the 40 to 50% range. And so, this is an especially hard kind of number to accurately predict, I would say, from the literature that's been published to date, going from everywhere from like 10% all the way to 40 to 50%. But when you look, across the different studies, it seems like about 30% is kind of the median estimate. And PTSD, is a little different from depression, in that depression, it can be associated with PTSD. It's a very common aspect. Some depressive symptoms, symptoms of low energy, low interest, and lack of pleasure from doing life activities, kind of impacts on energy and sleep, even sometimes to the point of, having either passive or active suicidal thoughts. These are the kind of core symptoms of depression, generally feeling and thinking bad about oneself. And that symptom cluster is oftentimes co-occurs with PTSD. But the key about PTSD is that, there's some major stressor that sets it off. And it can sometimes be a stressor that you witness as opposed to a stressor that happens directly to you, which is important to acknowledge and highlight for people who are first responders. Because, it could feel to some people like, oh, well, it didn't happen to me, so I can't have PTSD. But the symptoms are exactly the same, And so there's a growing appreciation in psychiatry that, we shouldn't base it on what the exposure was as much as what the symptoms are, because that's what's actually happening in someone's brain and what's impacting somebody's capacity to engage in their life in a meaningful and productive way. So with the prevalence of PTSD, it's not quite so high as depression, more in the kind of 4% range, 4 or 5%, on a kind of yearly point prevalence, and lifetime prevalence, maybe 6%. So it's, significantly lower. And that's full-blown PTSD. And it's worth mentioning in this regard that there's just an evolving science in psychiatry of, understanding PTSD. A new kind of diagnostic category has been proposed and is pretty widely accepted now of complex PTSD or CPTSD. Complex, sometimes called chronic PTSD. But, the little small exposures, oftentimes starting in childhood, of just being around really harsh conditions, can sometimes set all of the symptoms of PTSD into motion in a way that, then sets you up to really have a bad PTSD response to what for a lot of people might not be that much of a traumatic exposure. So these numbers don't include, these kind of really low numbers don't include some of the more newer diagnostic categories of complex and chronic PTSD. But when it comes to the first responder population, that kind of ratio of what percentage of those kind of 1 in 3 that develop depression and PTSD is PTSD, it's kind of higher. It's more in the 10% range instead of just the 5% range as you see in the general population. Makes sense, right? Because people are being exposed to much more regular and very dramatic trauma. To witness somebody's that you come to help and their head is cut off, or witnessing somebody losing their loved one right in front of you, and just feeling that loss, even if it's somewhat vicarious, it can really affect you. So I think that's, the kind of main stuff I wanted to talk about prevalence. It's somewhat meaningful in the sense that it, just kind of, it's not some tiny number, it's a significant number. And in terms of, treatment, I'm sure you've all heard of a number of the types of treatment that, psychiatry offers for depression and PTSD. And some of the kinds of medications that have been used over the years are the SSRIs, probably the most frequent medication, psychiatric medication in in use in the world today, you know. They can be very useful for a number of things: anxiety, depression. The symptoms of anxiety and depression that are part of PTSD can sometimes be modulated. In general, it's really well known that PTSD doesn't respond quite so strongly and beneficially to the SSRIs as depression and anxiety do. And even depression and anxiety, you know, we don't have 100% response rate or anything close to that. I use these medications a lot. I see the benefits. It's really amazing and beautiful when you see somebody's depression or anxiety that's been so crippling can, you know, just be relieved so dramatically over the course of a few weeks and stay better for a long time. And, you know, it's just fairly common that that's not the story too. So we really are in need of other treatments. And, you know, one of the other main treatments that's been acknowledged, studied, verified as a really important treatment in addition to the SSRIs and related medications is psychotherapy. And it's a whole story about why psychotherapy works and for whom it works and what forms of psychotherapy. But even there, when you combine psychotherapy with these kind of medications that tend to basically, you know, decrease the intensity of one's experience and one's, you know, these kind of thought, feeling cycles and loops that come across the mind and kind of take over and kind of put you in a depressed state or an anxious state. You know, these kind of medications and psychotherapeutic approaches to like understanding how to work with the thinking to kind of be a little bit more clear and maybe not believe all those thoughts that are kind of bringing you down. You know, even in combination, there's a lot of people for whom, you know, they end up just wanting more, you know, and they there's a well-known name for that group of people within the psychiatric world, which is treatment resistant. And so treatment-resistant depression, treatment-resistant PTSD, just not an uncommon clinical problem, you know, so we find you're working with. Chin, what's up?
And a very quick one for you. One of our members has asked if you mention acronyms, if you could please just spell them out for the audience.
Yeah, let me see, what acronyms have I
SSRI.
used? PTSD?
SSRI.
Okay, SSRI, PTSD. The
Yes.
post-traumatic stress disorder is the PTSD acronym. And SSRI, that's a selective serotonin reuptake inhibitor. And it may be even less familiar to hear SSRI than some of the really common ones like Prozac or Zoloft, Lexapro, Celexa. These are the kinds of examples of the SSRIs. They are medications that selectively enhance the availability of serotonin in the synapse because they, you know, inhibit the transporter that sucks them up. And they're certainly not the only thing we use for PTSD and depression, but they are the most common, and they're pretty, you know, emblematic of the other versions that are, you know, kind of takeoffs on that theme, where you take something every day and it just brings down the intensity of the symptoms. It oftentimes, you know, just makes it a little bit less contact with the, you know, the kind of the thought slash feeling that leads to that really stuck place. And doesn't necessarily, these medications don't tend to, you know, give deep insight or kind of a stronger awareness of, you know, what really is going on, you know, your unconscious processes or where this all is coming from. It just kind of deadens in a helpful way, hopefully helpful way, some people not, but deadens the intensity of the symptoms. Yeah, what's up, Karen?
I see there's a couple of questions in the chat. I can read them to you. I'll follow the chat for questions.
Okay.
So why do the meds affect depression more so than during PTSD?
Well, the best guess we have as a field in answering that is that you know, PTSD is a process that's set into motion in the brain and the mind by an intense stressor. And we know some of the brain areas, you know, that get overexcited and then stay in this loop where, like, you know, you're no longer able to be present to the here and now in the, you know, days, months, years after. You're stuck in this place where there's a part of you that's like, you know, still reacting as if this major trauma is happening now. And so medications don't help you kind of reprocess your experience and be with your experience in a more accepting and kind of embodied way. There's a part of the trauma where you kind of want to not feel your body because it's too much, you know, in that moment. But in order to really have some healing with PTSD, what we pretty reliably see, including, you know, every form of therapy that's been really found to work, is you have to help people to be with their experience, not just in the present, but also that experience that was so hard, which is the last thing we want to do because it, you know, it's triggering, but we have to find a way to do it somehow. And so the medications, you know, they kind of make it easier not to revisit that stuff because it kind of deadens the intensity of so, you know, I think that's really the reason, you know, they just don't get at the root cause in the same way. Maybe they're not getting at the root cause of depression either, but at least they're not kind of causing you to do something that will keep the depression going, you know. But if you do stay kind of disentangled from that inciting trauma, it's likely that the PTSD process in the brain will continue. What was the other one?
So the next one is a perfect segue to what I know you're going to talk about next.
Yes.
So the question is, why don't we promote the use of microdosing as a treatment with therapy? And person says, I know of programs in Canada where this treatment is done, success rates high for PTSD, especially with psilocybin.
Yeah. Yeah. So that is a good segue. Was there anything else before I go on that segue? Like another thing that's not so related to the segue I was going to go to anyway?
No, we have a cute comment about acronyms should be easily pronounceable. The letter abbreviations that are not easily pronounceable should be referred to as initialisms. So that was a cute sidebar there. But
Yeah. So yeah, you know, I was going to talk about this kind of new movement in psychiatry, which is the investigation of medications that you know, have a different model of treatment altogether. Not aimed at reducing the access to your memories or your kind of intensity of feeling, but actually helping you to experience feeling even stronger. And B, you know, not being a kind of daily treatment. In general, being assistance to therapy to help have breakthroughs. And so, you know, what I'm speaking about is the whole kind of movement of psychedelic assisted therapy or psychedelic medicine within psychiatry. And, you know, it was something that was progressing along as part of the field of psychiatry early on in its days in the 50s and the 60s, but because of the ways psychedelics ended up being used in the culture in the 60s, you know, there were some decisions made at the level of governmental oversight to like just shut down the research and the clinical implementation of this form of therapy. And so for many years, you know, it was such a taboo that, you know, there was just became a little bit of a misnomer, you know, like in general culture, there was this belief that those psychedelics, those really mess you up. And, you know, those are bad for you. Those will fry your brain. This kind of ideas became kind of popular. I'm in my 50s. You know, I remember as a kid, that was the word on the street. Maybe not the street, at least on the commercials, at least in school. But, you know, it turns out that the evidence from the psychedelic research, the psychedelic clinical research in the early days in the 50s and 60s was very promising for psychedelics. And, you know, the key is that you can't use psychedelics like you use Prozac. You have to use them in a very careful and considered way, or else you can have really bad effects. But if you use them in a careful and considered way, they can have very powerful positive effects. And that's, just something that is slowly but surely becoming more and more well established as a kind of a medical literature. The first psychedelic that became studied with enough reliability and replicability to be FDA approved and now used for psychiatric illness is ketamine. And that's what we're going to talk about, a bit today. But I'll just, mention in regards to the question about psilocybin. I don't know if the question was why isn't it being used? It's just because the research has not yet demonstrated it at a level of kind of sufficient reliability and replicability for the FDA to approve it and for it, therefore, to be legal for psychiatrists to use. As a psychiatrist, I've been in the field now for 15 years. And before that was, doing psychiatrically relevant neuroscience research. So I've been kind of parts of departments of psychiatry for many years. And it's changed over time. But now in the last 5-10 years, more and more of my colleagues, and not colleagues who have been long interested in psychedelics, just colleagues who are reading the literature about what's happening in our field, are quite interested to be able to prescribe these medications, but it's still illegal to do so, so they're not doing it. So that's really the reason. If and when it becomes, an FDA-approved medication, I have no doubt that just as with ketamine, which is being used at a pretty expanding and significant rate in our modern American healthcare system today, that will be true for the other psychedelics, including psilocybin as well. The question of microdosing versus macrodosing, it's really a question that requires, head-to-head research. Is it possible to get as much benefit from microdosing as you can from a macrodose? Nobody has shown that yet, but I know a lot of people are doing the microdosing, and there's some of the studies that are well controlled with microdosing have been equivocal as to how much benefit people get. Other studies have been pretty clear, like it really is benefiting people, but there's nothing like an FDA process that's been investigated yet with microdosing of psilocybin. These are all kind of one-off studies that sometimes are cross-sectional or kind of convenient sampling on the internet, or sometimes, a study of maybe 20 to 50 people coming to a university hospital research center. So, the kind of hundreds and hundreds of people being put through a randomized controlled trial to really understand if it helps or not is just something that hasn't yet been done.
I wonder if you could give like an overview of why is something considered a psychedelic and something is not, and what are maybe some examples of it before we dive in deeper.
Sure. So there's some controversy in the field. There's a field of psychedelic studies generally and psychiatry about what exactly qualifies a given substance to be called psychedelic. I think it's useful from my perspective, it's useful to just be true to the language. Psychedelic has a meaning. It means kind of soul or psyche manifesting. And so any substance that really brings something forth that's kind of a deep nature about the psyche, and the soul is where psyche comes from as a root, a Greek root. I think you can safely say, yeah, that's a psychedelic because that's what it's doing. It was a term that came about in the mid-60s to describe these agents that were being explored at the time, psilocybin and LSD primarily. And the use of the term for a medication like ketamine, which is different in the sense that has a mechanism of action in the brain where it's inhibiting a particular receptor that's related to memory, the capacity to kind of lay down new memories. Turns out you turn off that receptor that kind of keeps track of laying down new memories, and you go into this altered state that has some similarity to the altered state that this other kind of class of medicines, the psilocybin and LSD, also gives access to in a different way. And what are the similarities? Kind of a sense of timelessness, a sense of boundarylessness, a sense of more emotion being present, emotion that's many times been buried for a long time. These kinds of elements, are in common. And so that's why I use the term psychedelic, even for ketamine, even though it's not in the same class of the serotonin signaling psychedelic that the classic psychedelics are. But there is this commonality that, in all cases, if something's being called a psychedelic, people can agree on the notion that it must be an agent that is causing an altered state of consciousness that's temporary, and that temporary altered state of consciousness has qualities associated with, change in the sense of time and space, change in the sense of meaning, change in the sense of self, change in the sense of emotion. So all these different things kind of open up in a different way when you're under the effect of these kind of agents. And what's become, clear in the last 10 years or so, as a lot of scientific attention has really turned to the question of are these really possibly, clinically beneficial, is that for a substantial number of people they can be. There are some for whom it's really dangerous, people for whom, they have a background of bipolar disorder, for example, or schizophrenia. But for the large percentage of people, they are not dangerous. They're only dangerous when done in an unwise manner, without the proper support and preparation and grounding. And I think that's answers the question about the basics about psychedelics and ketamine. I think I'm happy to answer any more questions, but it might be time for Wilhelmina to take over.
I know, that's a perfect segue, but let's see if there are any other questions about what Rael has shared. Okay, and then I can't see everybody, but I don't see anybody. Feel free to speak up. I see my good friend Freddie Muse joined. Hey, Freddie.
Hi, Karen. Good to see
Okay,
you.
there you are.
God bless you. God bless you. Hey, that's a great presentation there, Dr. Khan. Very good. Very good.
Thank you so much. Appreciate it.
Thank you, man.
Freddie introduced me to Chen. Freddie is the chair of our community advisory board for the Cancer Center.
Oh, nice.
Yes. So we do have a question popped up. What if you have a high neurosis personality? Is ketamine good? Or, for example, hypervigilant naturally? Might it be might it not be indicated? Might it, what would you say?
I would say, somebody who's hypervigilant, kind of neurotic, which, for those who don't know the term,
sounds like me.
It's not like it's not like a super common term in psychiatry anymore, but it has a meaning which has to be like kind of tending towards a little anxiety, depression. So for people with those particular characteristics, they will tend to be a little bit more careful about doing a psychedelic because out of a fear like, oh, I hope something bad won't happen to me. And if you have a sense that there's something you'd like to work on with regards to, I feel like I'm just too hypervigilant and anxious, with the right support, therapeutic support and preparation, it can be helpful. It's not like the reasons why it can be dangerous for folks with a history of bipolar and or schizophrenia is that it loosens up the mind in a way that lets psychosis or mania take over the mind, the brain, And so those for people who don't tend towards those things, and if anything, a neurotic person with hypervigilance is kind of like an anti-manic or antipsychotic person. Like, that's a person whose brain is a little bit overly kind of rigid and structured. And so it is true that in general, the psychedelics are just more helpful for people who have too much order and structure and are like need to loosen up a bit, then people are already really loose. So
And another question popped up, and then we'll transition to Wilhelmina, who will do a deeper dive in some of these areas. The question is, for how long would you recommend drug therapy following an emergency incident? Is it temporary?
yeah, that is a very good question. And the truth, I mean, we'll talk more about this as a group, I imagine, because it's been something we talked about in the whole setup of what study we want to do. But although there are some psychiatric medications that have been explored to be used specifically in that period just after a trauma, and there's, neurobiology reasons why those particular agents have been explored for that kind of thing. These agents, the psychedelic agents, have not yet been explored systematically to look at is it better as an intervention immediately after the trauma or at some period of time later or much later? What's the relative improvement that you can offer somebody depending on when the treatment is done? And we just don't know yet. So I think, we can make up guesses and intuitions, but that's not so useful. The truth is that we really don't know as a field yet.
Yeah. So we'll turn it over to Wilhelmina, who is also the executive director of the Psychedelic Research and Training Institute, which is a national network that is training individuals to be facilitators and therapists in the context of psychedelic use, and a training that Rael and I both attended last fall to learn how to be psychedelic assisted therapists. And Wilhelmina, maybe you could tell us a little bit about what does this look like in practice, how you prepare people, what the experience, people report the experiences like, the integration process, and maybe you could talk about ketamine, but also, psilocybin, which is now emerging in Colorado and other places as legal within the therapeutic context.
Absolutely. I echo what my colleagues say, just in terms of just a giant thank you for your work. And as I'm listening to Karen and Rael, there feels like maybe what would round this out is almost talking about the culture in which these medicines are held too, because I'm also hearing that there's many people from not just the US here, but all around that are also gathering in a shared mission of providing service and emergency services and emergency responding. And there's this path of just immense courage and heart and resilience. It's really important. Having a background in community social work myself for the last, 15, 16 years, understanding what the persistent work of being exposed to many different things, many different calibers of traumas, over and over again, can be really challenging and hard. And I'm curious to also learn more about just the general arc of experience of someone who does this over and over in their career. And I know that in my career as a community social worker, there was really a time limit of how long we could be in the field before we were like, it's too much, I have to move on to something else. And so in doing this work with psychedelics, I'm really drawn to understanding if we can change that narrative, because there's so much wisdom in a space like this that has been carried on historically, that has been passed down, that there's so much skill that we really need all of you. It's important that you are healthy and that you are well to continue doing this work and that you're resourced. And so what I have found in working with just people who work in the line with acute trauma and being a clinical supervisor is there was constantly in my supervision of like, how it would always return to how they are taking care and resourcing themselves with the level of exposure that they have had. And I was reaching a lot of dead ends, was reaching you know, places where, like Rael was saying, some of the medication wasn't working and even some of the therapy wasn't working. And so when I came across psychedelic assisted work, I was really pleasantly surprised that there was a path for myself and for my colleagues that are doing very intense acute trauma work that is there actually a way to sustain us and not in a way of bypassing because we are good people with good hearts and can do good work, right? Because that can there's a limit to that, right? Once we're constantly exposed. But there was actually an encounter with this medicine that I learned through my training that began to foster a spaciousness of process and a humanity that being a service worker, you know, often becomes secondary to the service work. And so my hope is today that we can really just kind of expand this conversation around how we're tending to our humanity and potentially how these molecules or these frameworks of psychedelic medicine or therapy can steward that conversation as a priority for the sustainability of our work and your work. So just a little bit about what I do in addition to being the executive director of this training institute is that I work therapeutically and clinically, specifically with ketamine and starting to work in Colorado with psilocybin because in Colorado and Oregon, we can legally use psilocybin. And so when I first was exposed and got trained in ketamine, and had my own experience with it, I realized that this was a very like fast acting medicine that many of the people that I was working with didn't have to wait. What's the general window, Rael? Like 14 days, 30 days to start to see impact. When I had pretty severe clients really with treatment resistant depression and even some anxiety and PTSD, quite frankly, many of the people I was working with couldn't wait that long, you know? And so when I saw how quickly this could move and begin to move the needle of their mental health and begin to have at least at minimum some relief, then I began to understand that this is a medicine that needed to be hopefully accessible to community and in different forms. And from what I understand around like emergency responding work, it's done in teams and it's done in community. And so, you know, prior to the psychedelic resurgence and even before the 60s, all of this was done in community for millennia, right? When we talk about psychedelics. And so, and I'll speak to this all just like anecdotally, because like Rael said, there's not enough research out there for us to be as factual as we'd like to be. But what I sense was when there's like a disaster or a natural disaster or something that's happening in community, it is really helpful to be healed in community as well and be healed relationally too. And so with that, there were people that I was seeing individually, but for a multitude of reasons, we began to do this work in a group format. And when we started doing this work, we realized that yes, there was an effect of the medicine that provided relief, that provided just an ability to create some spaciousness between a reaction and a response, to people to be more insightful and to sit with whatever they're feeling. But a secondary benefit was that they were able to bear witness to their colleagues, to their friends, to their community members that were also experiencing something similar. And one of the things that tends to, I think, worsen some of their symptoms, or one of the symptoms of depression, is the isolation and the feeling that we are alone in this. And so when we begin to share the humanity and the vulnerability of what we're experiencing in what we call this like set and setting, or the container that we engage with this medicine, there becomes the secondary healing part of community. And so that's what we noticed over just like a series of time, that, you know, doing this in groups doing this in different routes of administration. And what I mean by that, when we talk about ketamine, there's different ways for the ketamine to be administered. And so I've worked with a few different ranges of this, and we're seeing benefits across the board. And like Rael said, we still have to screen, make sure that people are safe to use this. But I think ketamine is an interesting one as it's legal, as it's here now, but it invites in a paradigm shift of how we work with medicine and how we work with people and mental health. And like Raya was saying, that it doesn't necessarily like deaden or quiet some of those things. It actually creates an invitation to open and to be with a thing that is hard, be with a response, and it to be held in a loving and caring container so that you can reconstitute yourself in a very real way and begin to build memory around relating differently to what's happened to you, what's happened to your community, or what's happened to your colleagues. And so doing this like individually and group work in partnership with doctors and psychiatrists. I'm trained as a licensed clinical social worker. And so maybe I can pause there to see if there's just like any light bulbs or any questions that are coming up.
Yeah, there are a few questions, and well, there's one comment that from someone who says I'm not mentioning names, but people can see them there, but who's an MSW who works in mental health education, who says the burnout rate is very real, and that's a really good comment. There's a question, could this be helpful for situational depression, for current diagnosis of mental disorders? So I think like adjustment disorder, situational type. So thoughts on that? And there's a couple more.
I can speak like anecdotally, Rael, and I don't know if you want to speak on just like some of the more clinical. A lot of people that come to see me are dealing with situational or transitions in their life too, or maybe some of their standard ways of managing or coping with transitions, they're just not working, right? And so they're like, I've tried working out, I've tried talking to my therapist, I've tried all these different things, which maybe clinically would consider like treatment resistant. They've tried all of their different ways to move through. And they come seeking a different way of being with it. And one of the things that I noticed just from a therapeutic perspective is that the narrative that they have around their transition is no longer of service to them. And so we begin to invite in a different way, and it's, seeing their situation with different eyes. And sometimes this comes with having the medicine as an ally to steward that new narrative forward. I don't know if you have anything else to say about that.
This is on the situational depression question.
Yeah.
I think the majority of the clinical studies are looking at, full diagnostic criteria and showing, benefit there. The majority of the non-clinical studies are looking at folks who really don't have anything, situational or not. It's like, they're just doing fine. And, oftentimes looking at, the degree to which they have a really spiritual experience and a meaningful experience, or how their brain changes, that kind of thing. The thing that we are looking at in the two studies we're setting in motion is, people who are not having necessarily having a full-blown clinical condition, but having just some stress and anxiety and depression. And why? Because we think that the answer to this is likely yes. Whether you're using it as a way just to more fully explore your own potential and where you want to go with your life, or you actually are having some situational depression, anxiety that is getting to you, and you just want a little help. What you tried is not getting there. In both of those cases, there's good evidence, although not conclusive yet, but it's building that, yeah, those are applications where this kind of therapy can really be helpful.
So the answer is a yes, based on clinical experience for things
Yeah.
like situational depression. Another question, there's a comment, really interesting comment. It says during the Palisades fire for the CERT program, there was no hot wash. Teams would gather together after incident and discuss what went right, what went wrong, and what we dealt with and how. And that sounds like a really excellent practice and a way to come together as a community. So that was a comment. There's a question about how would a doctor or nurse take ketamine while working? Would it be dangerous? So ketamine's an anesthetic, so we can maybe take a step back and talk about what it is. At higher doses, it's an anesthetic that's used in medicine and the operating room and for pain. These are lower doses. It's not the kind of drug that anyone would take while they're working, because it would not be ethical or medically advisable, because for one thing, it affects your movement. And Wilhelmina's gonna dive in and tell you what it's like. Like, we walk in the door, this is how you get screened, this is what, the different forms of treatment, this is how long you're on it and what the experience is. But I'll just say that it's not something that you would take and go out and go to the store or drive or work or anything like that. It's something that you would take and be in a very controlled setting with a therapist and also physician supervision. And you'll get a better sense of that when we turn back to Wilhelmina. What symptoms should we look for in ourselves and our teammates that indicate stress-related or depression issues? Rael, do you want to take that one?
Yeah, happy to. I mean, the first thing, if you know somebody, like there's something different, right? So when there's something different and they seem to be, in some distress, like for people that a family member, a friend, a colleague you've known for years, like something's different. And yeah, in terms of what are the specific things, maybe you don't know someone very well, but you just can keep an eye out for something. And for PTSD in particular, one of the things that happens is you get jumpy. This easy startlability, like all your life, you've had a normal tendency to startle like anybody, and then boom, like you hear a loud noise and you just, it can be jumpy enough that it's obvious, even just like a door closes behind you in the room, people can get pretty jumpy when PTSD symptoms are starting. I think, in general, both PTSD and depression are marked by a tendency to start wanting to isolate. You just don't feel like you can be out in the world with others in the same way anymore, So one of the signs is like people just kind of being MIA. It's kind of one of the more common signs. And then there's the kind of just more obvious stuff, like, breaking down, crying, or kind of like just having a glazed look over your eyes. Well, the thing with PTSD, in addition to the startling and the kind of hyper arousal that indicates, kind of the nervous system is on edge, sympathetic nervous system is just roaring, is this tendency to be a little dissociated. The dissociation will happen right at the time of the trauma often, but then, people can kind of have this faraway glazed look, that is another sign that like they're dealing with probably a PTSD that's taking shape, Some of the stuff that I can think of off the top of my head.
Yeah, I'll add some things. So for PTSD, stress-related disorders, having, reoccurring thoughts, sometimes they're referred to as intrusive thoughts, that you kind of, Rael referred to this, you get caught in a cycle in your brain and you can, start to obsess about things, but you have unwanted thoughts and images and things pop into your head at times, and you have trouble kind of keeping it out of your head. Depression is taking pleasure, not experiencing pleasure in things that ordinarily might be pleasurable, and that relates to like people isolating and not going out, and it becomes a vicious cycle because when people start to feel depressed, they may become less likely to engage with others, but the more they isolate, the less pleasure there is, and the worse the depression symptoms can become. So those are some examples, but sleep disturbance, loss of appetite, weight loss, those are some other kind of tangible symptoms that can be associated with these as well. There's some related questions here that we can go with as well, which is how does one recognize that they're at a point when the situation is causing too much stress or depression? And I'll share one thought, and Rael and Wilhelmina also, but I would say in particular, what comes to mind for me is not being able to function in key areas of your life, whether it be work-related functioning, social functioning, enjoying time out with friends, family, and so forth. And really when the symptoms affect your quality of life. So ability to function and quality of life are at the point of it. And certainly at any point when there's any kind of suicidal thoughts or thinking it would be easier to be, that's like an extreme example, right? Hopefully this is recognized before it gets to that point. Anything that Rael or Wilhelmina would want to add in response to that question about when do you know it's too much stress or depression? Anything else?
I would just say, like, when you are caring for one another as colleagues, or even just like scanning yourself I find that it's helpful just to understand also like your recuperation and your recovery from an acute event or like a situation too. And so like when you are responding to something and you kind of notice like, hey, I usually need like a few days to kind of have my nervous system calm down, and then I can kind of get back. And then what I've noticed, some people are like, I cannot get back to my baseline, or I'm really frazzled, or I have nightmares, but it often sometimes looks like the narrative can look like, I'm not good at my job, I can't do this, like, what's wrong with me? And so it's generally because like your capacity to function or do the things that you enjoy, it's really impacted. And so, because we're usually very highly focused on working and productivity and doing well, sometimes the narrative takes form as being a bad worker or whatever it is. But just like sometimes it's good to notice of like what's coming up for me that's different this time. And I may not be managing as well as I maybe usually can. So those are good questions to check in with yourself and check in with your colleagues around too.
The only thing that comes to mind for me as a question, how would one know that one is just like taking on too much? You need to step back, at this time. It's the most general, but it's key to like recognize we all have a sense of what's true about our heart and our capacities. Like when you feel completely overwhelmed, you probably don't need to be spending more time out amongst the suffering. At that time, in order to maintain your capacity to be a healing presence for others and a helper for others in the future, you need to take some time for yourself. So I mean, I think that the truth of the matter is that will look a little different from one person to the next, but giving yourself permission as somebody who has, kind of a golden heart that you must have to just be doing the work you're doing with CERT, but giving yourself permission to have your own vulnerability. Nobody is, there's not a Superman, like we have some limit, And once you're getting close to that limit, we start feeling overwhelmed. Like, you know, and that overwhelm for some person might feel like, you know, you turn into a robot. You have no emotion. For another person, you might be irritable and, you know, getting angry. But like recognizing something's going on. Like I'm not myself, you know, like and trying to put a limit to not go above that if you can is, I think, a wise idea.
A number of additional questions. These are all great questions, so this is exactly what we were hoping for. So thoughts on symptoms of untreated PTSD from years past. I'll start us off just by saying, you know, that people can be still experiencing PTSD symptoms from something that happened a long time ago, and then there can be cumulative effects of different stressors or something that triggers a more severe response. But these would be things like unwanted thoughts and images popping into your mind, sleep disturbance, nightmares, you know, that hypervigilance, that agitation, strong startle response. It would be, you know, pretty much the same as PTSD symptoms from a recent experience. They may be less severe or less prominent as time goes on, but sometimes that's not the case. But Rael, as our psychiatrist, maybe you could speak to differences between acute versus more, I will say, chronic PTSD or PTSD from something that happened a few years ago.
Yeah. I mean, when I worked at the VA, you know, so many of the people I would be treating there had PTSD from Vietnam, and for, you know, decades had nobody talked to them about their PTSD because, you know, it wasn't a thing, you know, it's not a thing that was being acknowledged in the medical field. It was not a thing that was being, you know, supported within the veteran community to acknowledge to yourself. So it's common, you know, and that's certainly not the only population that has remote trauma that's still bothering to them to this day. It's just a common, you know, experience. And in fact, it's worth mentioning that, you know, a very good percentage of folks who present with PTSD related to something that happened pretty recently in their life, you talk to them and they never sought help before, but you talk to them for a while and you realize, you know, they had trauma from their childhood that, you know, predisposed them to having this trauma lead to the significant symptoms that they're coming to you for. So I think it's just important to acknowledge, you know, like that's a real phenomenon, and it needs the same kind of help. And what I mean by the same kind of help, you know, the combination can be medications, can be psychotherapy. These kind of remote traumas oftentimes are really benefited by psychedelic therapy too. You know, like there's not a real distinction other than a few kind of really experimental treatments between what kind of help we can offer. You know, is it more likely to make a difference for people whose trauma is from many years ago versus the last couple of years? In general, it is a similar brain thing, and it's just become, you know, a little more kind of encased in kind of like a fixed pattern in the brain and the associated kind of feelings and function, but it's still treatable. I think that's the good news. Like you could imagine, you know, having a fear like, oh, it's been with me so long, like it could never be helped now. That doesn't seem to be true. You know, even these more remote things, if you really start putting some attention on them with the right support, can be resolved.
Kind of relates to the next question, and I don't know the answer to this one. Are there numbers or statistics on the proportion of those with severe depression and or PTSD that never go back to work, whether it's paid or volunteer work? And is it the employer who decides who can or cannot come back to work?
That's an interesting question. You know, it's two different realms of question too, right? Like, what's just the reality of what percentage of people have a depressive kind of course that's so bad that they can't work, and what percentage of people have such a dramatic course of PTSD that's so bad that they just can't work. And, you know, in both cases, all I can say, I haven't seen numbers for this, and there may be some numbers that you could find in the published literature about it, but it's relatively small. You know, having practiced for 15 years, I've only seen, you know, a handful of folks who couldn't work for at least a year or more, you know. And those handful of folks that I saw like that, you know, like they got to a place where they really couldn't function. They were doing their best, and you know, there's always those people who are like malingering and pretending, but you know, for people who seek help, typically they're doing their best, they're trying, and they just can't get themselves functioning again. And so then there are these mechanisms that, you know, exist, and it depends on the employer and what kind of insurance you have and what kind of workers' compensation, et cetera. So it's very conditional based on these things that, you know, it's not universal to our country. But you can, as a physician, write, you know, this person does need to have time off. They cannot function for this reason. It's not that they're being lazy. They're just, you know, disabled. And you can get that time off. And I don't know, I think my memory is that a lot of times it's a year or two, and then after a couple of years, you know, you're kind of out of luck in terms of being able to keep being paid by that employer. But if you have a disability insurance, of course, that's another story that you can potentially, you know, have some level of income for life if you're lucky enough in that situation to have had that kind of insurance.
Yeah, I think there's also like this part of it where like there's some realities where people like they can't leave work, right? Or they are committed to this work or need to work and need to keep on going back into these like settings. And you know, I've had similar experiences with folks at PTSD that are just from discrimination, from trauma, from societal trauma, where they can't remove themselves from society, right? So they continuously are in this place of feeling under attack. And what I find with some of the work that we do with like psychedelic assisted therapy, it's around like steadying the nervous system enough so that they can be where they need to be. You know, like ideally, if they have the room to take time off or have a whatever plan, and some of them don't, right? And so it's how can we get them to a place of being well enough to continue to do what they need to do in their daily life too. And that ends up being our goal. But it's so individualized, like you said, because of their insurance employer or their just individual need to continue doing what they need to do.
You. Gosh, we have a lot of questions, so we'll keep going. Okay, dovetailing on Carl Ginsberg's question. When it comes how do we know when the assignment is causing stress? Our CERT people who work this event insist on being on the scene for hours upon hours or even days. It's what makes us amazing and it's what makes us really have to, it makes us amazing, and it's what makes us really have to do this. You know, should we have a limit on any given member's service during an emergency like this? On average, some of our members worked up to 18 days out of the initial 25 that we were there. Should there be a limit imposed? That's a really interesting question from Chief Chin.
I think it would require some study to know a really, you know, evidence-based answer to that. There's the kind of, you know, folk
The
wisdom.
scientist answer. The thing is, it's everybody's different, right? So if you
Yeah.
choose some limit, maybe I don't need that limit. Maybe I need a lower limit, and because everybody's so different, it's hard. And so it makes me wonder whether the focus is on helping people recognize when it is getting to be too much for them, so they can self-identify as, okay, that's my limit. But I think imposing a limit's hard because there's so much variability in people's coping mechanisms, their history, the number of stressors they've been exposed to before, and how their body reacts to these, that it might be hard to impose a limit that works for everybody, would be my thought. I don't know if you guys have any different thoughts about that, other thoughts?
Yeah, I feel like that's challenging to just say right off the bat, but I think it's like from a potential like manager perspective is the type of questions you inquire with the people that you are overseeing too, right? To help you understand the variations of their limits or where they're feeling activated and what you notice in them too, to make some of those like individualized recommendations too. But it's hard to tell because one person may be okay working 15 days and be fine, and then others may work 5 and may need more time to recover. And all the emergencies could be different contextually too.
The things that perhaps we can offer after this is there are some symptom checklists that are used. Some of them are used in research, some of them are used by clinicians. It's not to self-diagnose yourself. We're not suggesting that, but maybe we can give you some, some people have asked what are the common symptoms. Maybe we can follow up with a list of the types of experiences people have that would be a sign that it's important to go talk to somebody before, especially if you're, working in a stress situation like the fires or some other emergency response, to be able to recognize that maybe that you might need to step back a little bit. If that would be helpful, we could certainly do that. It's not but again, it wouldn't be a way to diagnose oneself or for somebody to diagnose somebody else, but just these are some of the things to look out for.
I think it would definitely be beneficial to have that symptom checker, another
Mhm.
tool in our resource, because we're always at least in pairs, and
Mhm.
being able to check in with each other before and after we go out is critical. And
Mhm.
having that tool in our chest is going to be very valuable.
Absolutely. So we can definitely do that. So we have a lot more questions. I see though, we also have a hand raised, Mitchell Jacovis.
Mitch Jacobus.
Mitch Jacobus.
I'll answer to any of that. And there's just so many reading the chat and the questions. I couldn't type fast enough. One, you know, the Palisades was different for all of us. It was such a prolonged thing. I am on the call out team for South Bureau and us here on the CERT, but I also got to serve, and I'm a volunteer patrol officer for LAPD, and I was assigned to the fires on that side. One of the first day at the command post, it was about the 4th day after when the fire started. I'd never seen this, but we had clergy and clinical people walking around just talking to us, coming up and just checking in, and so I think Freddie was saying something, there should be somebody assigned. We had multiple people, all clergy of different faith and social workers checking in, plus we had other services available to us. For me, and about the days off, I knew after 3 days on the line, I needed a day off. Yeah. And this hit me differently too, because the first day I was out there, I've been watching on the news and we saw the devastation, but to see it firsthand, it's like a baseball bat that hits you. And then when you go to see your friends' houses that you celebrated at, and they're gone. So, but I did find that the more I was out there, that first day just blew me away. But the more I was out there and interacting with the victims, the true people that lost their houses and stuff like that, and how appreciative they were of us, it just really helped. It really helped. And that drove me going back there more often. Yeah, it was different. But I think that answered like Freddie's question about having people there and the time off. You really do need to take a self chat. I think.
Thank you for sharing that. And I totally, get that sense of, feeling that feedback and having that connection with the people who you're helping, and how that would be enriching and fulfilling in a way that would keep you coming back. That makes a lot of sense. But it also says a lot about who you are and who this team is as well, which is important. We have a bunch more questions, so I'll
I
keep
wonder,
going. Yeah.
Karen, just a
Yeah, sure,
suggestion.
please.
I wonder if it would be helpful in terms of getting the full range of questions out there, for Wilhelmina to describe that process of just like what does the treatment look like that we're talking about with this ketamine assisted therapy, because I don't think we quite got to that yet.
Yeah, I'm aware of that. Absolutely. And we'll make sure we get to all the questions, and maybe just walk us through, like, experientially, if I was a client, what would what would it look like? What would my experience be? And what are the different elements of the practice of the use of ketamine, which is now being more widely used in the context of PTSD and depression?
Sure. Can you tell me the time, how much time we have left so I
We
can
have till
kind of,
9 o'clock. We have about a half hour, so maybe take 5-10 minutes, and then we'll respond to the remainder of the questions. And I think it's less critical to describe the details of the study, because the program's not going to be starting for a while. We could always come back. I'd rather we make sure we answer the questions for folks here. So maybe take
yes,
5-10 minutes. Is that okay?
sure. Yeah. And so I think maybe just like even hearing a little bit around what everyone's saying or typing, or what the potential things like that we would be addressing. So someone would generally get a hold of our clinic and say, it could even be like, I'm an emergency responder. I've been doing this for years. This most recent fire has really taken an impact, and I can't sleep, and I'm just not coping well. And my nervous system is super frazzled, and I don't know what to do. Right. And so they would come in, and I would screen them to just better understand what's happening in terms of their mental health. And then I would have one of our psych nurse practitioners or one of our psychiatrists then do a secondary screen around mental health, around history, and generally if they are appropriate for this medicine. So if there's anything that they're currently taking, or any of their history, which would indicate this medicine was appropriate or not. And so if they are appropriate for this medicine, then they would pass that clearance. And then we would spend some time, what we call this just like arc of treatment, which is like some preparation, work with the medicine, and then an integration of that experience. And that is kind of the whole framework that we work in. And in the preparation, what we're doing is understanding what's happening in terms of someone's like just mental, emotional, spiritual landscape, what led up to this point, and really exploring their intentions and their hopes of what they can address or be with the support of this medication. What I also share, what tends to be different, I think, in this frameworks, and what also tends to be helpful, is the setting that we create in this is one to invite in the psychedelic space, we call it your own inner healing intelligence. So it's more of inviting in the wisdom that you have in you to be able to work and to heal and work through whatever you're experiencing. And I think this is a really important aspect, because instead of just seeking like externally for like a fix or a solve, we're not doing that. We're working with you or the person that's in the clinic to be able to access all of these different resources in them, so that they can sustain these gains beyond the work with me. And so we do the preparation, we answer all the questions. We also understand what it's people's relationship with like non-ordinary states. And so and I will say like non-ordinary states don't have to include like psychedelics. We go into non-ordinary states all the time, right? Even like Mitchell, what you said, it's like we sometimes go into a non-ordinary state when we're experiencing something new and something maybe even horrific or something that's life-changing, right? That becomes a big shift in our system. And so, you know, beginning to familiarize ourselves with what that would be like, any fears that come up. Somebody talked about like being anxious of like what it might be like to temporarily not have control, right? And so with multiple prep sessions, we understand that. We talk about potential like dose or route of administration. And there's different routes of administration with ketamine. We primarily will we'll use like an intramuscular dose, which is going to be, you know, just like essentially a shot in the muscle or in the arm. And when it comes to what we call administration day or your medicine day, we come in and we do any extra prep or we talk about intentions and usually do a grounding and then we work with the medicine. And so the medicine is administered and a playlist that's specifically created for you is played to be able to enhance the experience. Yeah, in headphones and with eye shades. And so what we invite is for people to be really internal with the experience. And the hope is that you move beyond what your normal loop is and begin to explore what's there if you're not running the same narrative. And often that narrative is written with like trauma, anxiety, depression, but we get a break from that, hopefully. And then we begin to explore what else might be there for you, what other parts might be available for you to be with and resource you. And really, that whole experience is probably an hour, 90 minutes, if that. Then you come back to an ordinary state and then we actually work with you as you're landing. It's really important that we offer some time to work with you in that landing because of this like window of brain plasticity, this window of openness, and where kind of our fear center is also quieted. And so one of the many challenges of working with PTSD is there's an activation of the fear center and all of your different defenses come up. But with this medicine, it actually quiets some of that so you can be with some of the scarier parts in a way that hopefully can be empowering. And so after you're good to go and you have your medicine session, in the days after, we have what we call integration. And so we invite in of how you weave this experience, the insights you have, the thoughts that you and feelings you have. How do you actually weave that into your daily life in a way that is generative, that is helpful, and that can sustain you? And so that's the entire like arc of the treatment that we go through. And so headphones, music playlist. Yeah, so in the headphones, it's usually a playlist. It's usually a novel playlist because we are so good at associating and remembering things that are queued up by music or words. So it's usually a nonverbal novel playlist that will help the mind do the exploring that it needs to do. And so yeah, and then we weave that in, and some people will come through a series between like 4 and 6 sessions, and we'll follow that same standard role of medicine integration. And we see how folks are doing after that. Many people can find relief after the first 1 or 2, and then we start to see sustainable, like I will say anecdotally at our clinic, we would see some sustainable shifts happen after 4. So let me pause there. Does that feel like it kind of illustrates a little bit around what this type of work looks like? And sometimes it's done in group, sometimes it's done individually too, depending on what we see as the right fit.
So thank you. That's really helpful. And before we go through the rest of the questions and comments, maybe I'll kind of go out on a limb and share my experience, just to give a sense. And so we all have different traumas and life experiences. And sometimes, I mean, for me, I didn't even realize like how much these experiences I had were affecting me, affecting my anxiety level, my quality of life, and until I had the experience working with psilocybin, which for those of you that, some of you are familiar with the term based on your questions, but it's what back in the 60s and 70s were called magic mushrooms. So they're psilocybin is a chemical extracted from the mushrooms. And then also with ketamine. But, you know, very briefly, I was the primary caretaker for my father through his end of life care, and a couple of years later for my mother. And I never really thought about it as trauma. I took care of my dad, then I took care of my mom, and shortly thereafter, I left Philadelphia, moved to California, took a new job, and really just kind of escaped the environment and didn't deal with a lot of the feelings that I had around this, but I was experiencing things in retrospect. I see, like, I'd have images popping into my mind from some of the most stressful aspects of those experiences of being with them through the end of life for different, very different but difficult diagnoses that I hadn't dealt with. And so in the experiences, and I'll just talk generally because they were somewhat the same with the two medicines, during when the medicine was taking effect, I wasn't specifically thinking about those experiences in detail. I was just kind of a very relaxed, like not sense of no anxiety, fear, but a kind of a floating feeling. With the psilocybin, sometimes people see like colors and shapes and things. I saw some of that. But in both experiences, it was after the experience and kind of sitting up and starting to have a conversation that just, I started talking with the therapist who was doing the session with me, and it just, I cried like intensely, and I'm not somebody who cries like hardly at all. And I had this like emotional release where I was sobbing for a half hour, just crying. And then talking about like just those experiences. It was clearly related to those experiences. And so I had this intense emotional release both times that I tried this in the therapeutic setting, that really surprised me because I hadn't realized like how much I had stuffed down and not dealt with. And I will say that those two individual experiences, which were about 6 months apart, that after in the weeks and months after, I felt like lighter, that something had lifted, like this pressure in my chest had somehow lifted. And it makes it sound almost magical because, you know, it's like you do something once and it has this effect. But for me, it was very, very profound, and it brought to the surface things that I needed to deal with. And now I can actually go back and think about those experiences, and I can think about the good times before the end of life care in ways that I wasn't able to before. So that's just sharing for me personally what the experience was like to give you a sense. And sometimes you don't feel it in the moment, but you slowly, in what Wilhelmina called the period of plasticity, that just means your brain is more flexible. And we know that connections in the brain change and things open up in the weeks following it. So I was able to just process, and it really had a very positive impact on my quality of life. So we'll go to Sally Thompson, and then we'll go through the rest of the questions. Sally, please.
Yes, I just want to express my thanks to have a trio of highly educational people on this subject that have done extensive research and still be able to tell us and explain to us in layman's term has been an exceptional treat tonight. Just want to thank you for being able to do this for everybody. It's very educational, and tremendous thanks to all of you.
Thanks for sharing that. It's a real honor to really be here and be able to share with you. All right, we have a lot of questions. So there's a question about the self-assessment tool that would help score someone's status and when you might need to refer for recommendations or if this score means that. So what we can do is provide general information. There aren't tools that you can kind of diagnose yourself that would say, if you check these things, this means you should go to the doctor because everybody's different, but we can give you some tools that will give you a general sense. But I just want to be real clear that there's no like self-diagnosis tool that is valid that we can give you. But I think what will give you a packet of information that you'll find helpful, and we can continue the conversation for sure. For professional first responders who work in teams, they might have to check in with a supervisor. For CERT members who might be deployed in pairs and go pick up a vehicle without directly interacting with a supervisor, what can be done to make sure that either the pairs are checking in with each other or should be done to make sure that dedicated members aren't overworking themselves or repressing or hiding trauma? That's a great question. Well, this is one thing, to have people who are experienced, working with clients and also with the research to share and increase awareness of that. That is the very first step. Rael, Wilhelmina, are there other thoughts about, how to ensure that people aren't overworking themselves or suppressing hidden trauma?
Yeah, I mean, I think to start even just having this conversation and having us here to like normalize that all of this happens in this work. And I think what the question is also speaking to is an invitation of like collective care. And so how we promote caring for one another in this work and creating a culture of care too, of like in some industries, it's kind of this like grit down and move through it and don't talk about it versus like checking in with one another as the norm too. I said, so I think the more people do it, the more it's normalized and the more it is uplifted too. So I think the way that the culture of this work is created can really support that too.
Thank you. So, question about how would you define PTSD and CTE in a person? I'm not sure what we're referring to with CTE, but we can talk about how
Chronic
go ahead.
traumatic
Val, please.
encephalopathy,
Oh,
it
okay.
refers to that, multiple TBIs, you end up with CTE, kind of a relatively newer diagnosis of neurology that has a lot of psychiatric manifestations. CTE, it's still kind of relatively unexplored in kind of mainstream psychiatry. It's like if you happen to be a professional athlete, a football player, there's a good chance you'll be put through a protocol to assess whether you have the signature symptoms of the irritability and the distractibility. It's kind of like some combination of like having a very short fuse, very easy to anger, and kind of ADHD symptoms, like you just can't stay focused and kind of being a little bit both distractible and hyperactive. And that's the kind of complex of symptoms that seem to result from these multiple traumatic brain injuries. And it's different, having CTE plus PTSD, that's a horrible situation. Of course, some people have it, especially veterans who are in blast, but they're not the only ones. But you can basically have both things. One is not, does not preclude you from having the other. And so what it looks like when you have both is you've got all the symptoms of PTSD, the hyperarousal, the avoidance, trying to avoid anything that might remind you of whatever that was. Oftentimes a big part of avoidance, you just don't want to go in crowds at all, just because being around people is usually where traumas happen. and the depressive symptoms, and then on top of that, the anger, irritability, and the kind of inability to focus. That's what it looks like. It's really horrible. And if you happen to see someone with all those symptoms, they might have that. But the big thing with CTE is in both cases, right? You have a major trauma. Things got different after the trauma. And with CTE, you have a major hits to the head, usually multiple, but it could be one big one.
Thank you. And I was just, scrolling through the comments. They're mostly comments rather than questions. And there are a number of comments, just to summarize, and then there are a couple of questions, but about the value of debriefing and, with your colleagues and friends and others to share what you're feeling. Related to that, a comment about whether it might be helpful to have mental health professionals on site. And some comments about people's experience and burnout, and emotional animal support. I know my dogs are like a wonderful source of support for me, so I can definitely relate to that. There is a question about, is this headphone playlist music, talk, or sounds? So the playlists vary. There's no one single playlist. In my experiences, it was what I found really useful was instrumental music, typically, not singing, sometimes some chanting, or sometimes there were some voices, but typically instrumental music. But different therapists, and that's, I don't know, Wilhelmina, you've done a lot of this through Prati. Do you typically use music, or you have any thoughts about different forms of what's played in the headphones and how that might have an impact?
Yeah, it's usually music. We call like music the hidden therapist in the room, and there's like a carrier wave of it that helps move the experience along. So it's usually music, usually with no language really.
Mm-hmm. And someone asking, Rael, you're gonna love this question about meditation and deep breathing and whether that helps. Do you want to? Rael leads the Center for Mindfulness at USC, and go ahead, Rael. I won't steal any.
Yeah, and I saw that Karen also added on that Tai Chi, controlled breathing, mindfulness are very helpful for her. And yeah, generally, meditation, deep breathing, I will point out that there's a distinction there. Like deep controlled breathing can really help calm the nervous system very quickly. And so it's separate from just general mindfulness practice that I'll explain in a second, but it's a really useful tool to have. If you notice yourself in any condition, whether it's, going out to help in an emergency or just dealing with the stress of life, like noticing like I'm getting dysregulated, my heart's beating fast, I'm starting to breathe quickly, etc. Just taking a few minutes to slow down your breath on purpose and just be present with the breathing process. It will actually, shift the balance from being that sympathetic fight or flight to a parasympathetic. And of course, it requires you to be able to have like a moment of silence and not have to respond, in the moment to some quick action, right? But if you do have that ability, it's a good thing to do to regulate yourself real quickly. The mindfulness meditation practice also will be generally kind of calming, but not in that really kind of direct kind of manipulate your nervous system now way. It's a little bit more like settling into with whatever's happening, and building that capacity that we all have to be present to what's happening in a more decentered, spacious way. So kind of the thoughts, the feelings coming and going, and just being present to them instead of identified with them is kind of the essence of the mindfulness practice. And you can come to recognize, oh wow, that voice in my head is not the only thing, that's not the only game in town, you know? And so that kind of practice, you know, whether it's sitting or laying down or while doing Tai Chi and kind of keeping the body in motion and being present to, you know, the awareness of this process and not the kind of thoughts about things, you know, those are all really helpful practices that, you know, I think are also very complementary to any form of psychotherapy and specifically psychedelic assisted therapy. A lot of what we're doing as clinicians when we try to help somebody get a positive experience from a psychedelic therapy is helping them be a bit more mindful with whatever comes up, you know. So they are complementary kinds of things.
I would like to make a comment too, if possible.
Sure, and then we'll go to Carl, who's been patiently waiting. Please go
I
ahead.
didn't know how to wave my hand in the video.
That's okay. You go,
So-
and then we'll go to Carl.
I think because we're all on this and we're having this discussion on how we can help and figure out the stressors. I think number one, we need to know where we stand and how we're feeling. And when we talk to another person to see how they are feeling, to not throw it out there brashly, like, dude, you're out of control, you need to slow down. You know, and you approach it more like, you know, you seemed really stressed. Can you take 5 minutes to step aside? Just, you know, to calm down and maybe talk to somebody. You can go back to working and we're not removing you, but you're sounding a little out of control. So maybe we just need to take 5-10 minutes. If you're doing the 3 weeks as the Palisades Fire, take an hour in your truck, close your eyes, if music does it for you or whatever. But I think how we approach people that are stressed out is really important. And since we're having this discussion, if someone tells you that we take the time to acknowledge, oh, wait, I am doing something a little crazier, and take some time to reorganize your thoughts by stepping away just for a little bit of time. I know it's hectic and it's busy and there's lots of things going on that we just need to be more aware that if someone's pointing it out, then something's wrong. Like we're losing our control with it. And as for like PTSD and complex PTSD, you can work through it, but sometimes you get in a situation that triggers it and you just get that blast of, oh my God, we're going for the roller coaster. But if you've been working through that process with a therapist, or if you have to use medication or this new program you're doing, hopefully you have a set of tools, if you've already addressed it, that if you do step away, you can access those tools and be like, okay, this worked for me. This is not the same situation as before. I have control with it. And, you know, you can always talk it over with a friend. And we just have to be more open that if someone wants to talk to us as well, that we stop and listen. So that's like one of the biggest, I think, things. I haven't been in an emergency situation, but I am a PTSD, complex PTSD survivor of sorts. But, you know, we have to know what our toolboxes are. And we have to know how to help our colleagues, especially if you're in the field. I'm pretty sure you could tell if someone's losing control. Try to rein it in and just remind yourself, if you are the person getting approached, asked to calm down, that you accept it and be like, okay. But it's a two-way street. There's no diagnosing you're this, and this, and you're out of control. We both have to be on the same page to come together, because we're really about community and helping and moving forward. If we can address that, then I think we can have a better outcome, because a trauma situation is a trauma situation. You're going to have effects, but it's just how we choose to deal with it in the long run. So that's just my 2 cents.
Thank you. That's very insightful. Thank you for sharing that. Carl, now we do Carl, and then maybe we'll turn it, I think we're at the end of our time. We'll turn it back to Chin. And Patrick had some very helpful suggestions for breathing. That might be something we can include in the materials we share as well. Carl.
I wanted to comment on the challenge of the hot wash.
Mm-hmm.
We work in pairs. I know that if I was out with Chin, for instance, who I've known for 9 years, and I was feeling stressed out, I could go to Chin and say, I'm stressed out, I need to back out. our people don't know each other that well. Some of them don't like each other. Some don't want to work with each other, but sometimes they have to. I did 3 years with the mayor's crisis response team. We had a psychologist, I believe he was a psychologist or psychiatrist, on 24-hour call. The person who led the program was a social worker. So anybody could get on the phone with the psychologist any time of night after an assignment. And we saw stuff that's a lot worse. I mean, I've seen in the 65 calls that I did, I've seen things that you wouldn't believe. And it never really bothered me, but I always knew that I had that support behind me. It's not realistic to think that we can all stand in a group and pour our hearts out because we don't know each other. We know each other when we go on assignments and we go out and we hand out hydration to the firefighters, or we do an event, blah, blah, blah. And we have never had any training for this kind of a situation like what happened in the Palisades and the other city. So none of us are really equipped unless we've been trained somewhere else to recognize in other people what their stress points are, or their triggers, or what did we used to call it? They were triggers and there were being bitten, right? There was 2 levels. And the last person that we would ever talk to on that level would be a firefighter, because they're not trained and they're Supermen. And, a lot of them go down bad because they don't deal with their stress, because they think that they can work themselves until, at the nth degree. And because they're Supermen, they're never going to be bothered by it. So we don't have that kind of support, but it's incumbent on the fire department, I believe, to, now that we've all been through a traumatic event en masse, collectively, all of us together. We weren't all together. We were in different places, different times, different functions, but we all saw the destruction, and there has to be some kind of a reaction. You can't just see hundreds of thousands of homes burn down and just walk away and go, well, no big deal. It doesn't work. But we don't have a person in the fire department that we could call up and say, I'm having a problem with this. And something like that would be beneficial. And I don't know how we do that, but it's probably something that we have to talk to our command about.
That's an excellent point. And I was taking some notes and thinking that, I see this as like the beginning of a conversation with all of you, but it is part of the materials we can pull together, not only kind of symptoms to recognize, breathing exercises, but how to access different resources. And then, I would say we're happy to come back. When our program moves along a little further, we can come back and tell you about that. Like I said, it's not available yet, the ketamine program, but we'd be really delighted to put together a packet of information, and then we can go back and forth and see how we can continue to share information as we get to know you better, and also get to know what the needs are and what would be beneficial. So maybe at this point, because it's just 2 minutes before 9, I remember saying to Chin, really, do you think that, that people will have enough questions and comments that it'll take 2 hours? Do you remember, Chin? Oh, you're like, oh yeah. Yeah, could easily. And so.
He delivered.
Our meetings with Chin always overrun, so don't, this is not you.
Well, blame it on me. Okay, we're having a moment.
Like the newsletter.
We usually do. Yeah, like the newsletter. I'm still reading the one from 2 years ago. I haven't gotten through it.
Like I said at the very top of this, it's like me and the newsletter, we're like our own little therapy session there. But
well, there is research that writing
one.
about traumas is very therapeutic too.
Yes.
So
and everybody, it looks like we are getting close. I know Patrick's out there someplace. it looks like we've had amazing engagement over the evening, and this really is, and I agree with the doctors and everybody who's here that this has to be a continuing discussion. This can't be just a one session, one and done. It's like this is a very complex issue that we have faced. We will continue to face it, and we've worked other incidents over the years, and and who knows, we've probably had members who never really talked about what they felt after they saw, and we just don't know. But this is going to have to be definitely a continuing discussion with you folks. I think the three of you guys are the best. You guys have put on a really good presentation tonight, and for everybody else, the Q&A has really steered this to where the conversation needs to be. Patrick, I'm going to throw it back to you, but I will say before I let everybody go, I want to say thank you to everybody for the privilege of your time. Wilhelmina, Rael, Karen, especially you guys bringing all that knowledge here. Thank you guys for the privilege of your time, because as I always say after these presentations, we could be nearly anywhere right now, and not hearing us yammer on about whatever it is we're yammering on, which is important. But thank you guys for being here. Patrick, floor is yours.
So somebody asked about breathing, and one thing that I've learned, it never really worked for me, but I've heard that it works for other people. It's called box breathing, and that's breathing into your stomach. So you kind of push your stomach out, not how we normally breathe, but you breathe in for 4 seconds, you hold it for 4 seconds, breathe out for 4 seconds, hold it for 4 seconds, and then repeat the process, breathing back in again. That didn't work for me, but I did read about Miyamoto Musashi, a samurai who's fought 63 duels and survived them all. And he practiced breathing in through your nose for 4 seconds and then breathing out through your mouth for 6 seconds. And that one actually works for me. So I recommend practicing that. You feel yourself beginning to become anxious, your body actually stops breathing. And that deprives your brain of oxygen, which causes the situation to get worse. So practice breathing if you feel yourself starting to panic or start to get into a situation that you haven't experienced before. Focus on your breathing. Get your breathing under control, and then you can start thinking clearly and hopefully get through this situation. Thank you, everybody, for coming. Hopefully you got something good out of this. This is up on your YouTube channel, so share it with your friends. And then we'll be back next month. Next month's topic is going to be sheltering in place. Home is where your stuff is. So we'll talk about if you can do that, and then having a bag ready to go in case you need to evacuate. Thank you, everyone. Have a good night.
Thanks for having us.
Thank you, Dr. Learman,
Karen, yeah.
Del Castillo, and Khan. Have a good night, everyone.
All
Thank
right.
you.
Thanks,
Bye.
Karen.
Good
Thanks,
night.
Karen. God bless
Good
you.
night. Bye, Freddie.
Thanks,
God
Doc.
bless
Thanks,
you.
Chief. Thanks,
Bye,
Patrick.
everybody.
Karen,
Bye,
Patrick is
Jen.
our other
Bye,
chief.
Patrick.